in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. This is Buck Joffrey, and today I'm going to tell you a little bit about my visit to my cardiologist. Actually, it was the first time I'd seen this guy. First of all, why am I seeing a cardiologist? Well, I actually don't have any problems with coronary artery disease. As it turns out, I have a history in my family, not immediate family, because my father is fairly healthy in 85. My mother is fairly healthy in 79. Neither one of them has ever had any sort of cardiac event of any kind. My mother does have atrial fibrillation, but it's not coronary artery disease per se. But on my mother's side, all of her brothers had heart attacks, myocardial infarctions, as we say, in their early 60s. And my maternal grandfather died before I could really remember him, and he was, I think, just 62 years old, massive MI. So for me, ever since once I turned 40, I have been a little paranoid. I think I had an event when I was 40 where I felt like maybe I was feeling some chest pain and was concerned and started talking to my doctors. It turned out it was nothing. It was probably something completely unrelated. At that time, I had a special kind of CT scan called a coronary calcium CT. Basically, the idea is that it looks at how much calcium is in your coronary, in your heart blood vessels, your arteries there. And what it's telling you is it tells you what's kind of happened already. If you recall in some of what we've discussed about sort of the evolution of cardiovascular disease, coronary artery disease, what happens is that generally you get these plaques because of the insertion of lipids, particularly ApoB, into these artery walls, and that causes an immune reaction. And that starts out creating what's called a soft plaque, ultimately from the immune reaction, and those are very dangerous. Once it heals over, it leaves calcium behind, sort of like you can think about it as almost sort of like a scar, some scar tissue. So that's not very dangerous itself, but it kind of tells you what's been going on in your heart vessels. And at the age of 40, you should have your score should be 0, and mine happened to be 1, which wasn't very alarming, but at the same time, I didn't like the fact that I had a score that was not normal given my family history. So at that time had taken the position that I would just start a statin, even though technically I did not have high cholesterol. Now, that was 10 years ago. 3 years ago, I again took sort of the next step with intervention and went and saw a cardiologist in Colorado for prevention again, who ordered something called a Clearly study, which is basically a CT angiogram, which basically means, it's kind of looking at the blood flow, coronary angiogram, CT of the blood vessel of the heart. And then they added artificial intelligence to that. That's the part that makes it the Clearly study. And that was able to tell not only what were active, softer plaques that were more dangerous, but also which ones were calcified plaques. So completely different level of testing. So everything was generally fine. But again, because of my history and because of some mild coronary artery stuff going on already, the decision was made to be pretty aggressive and to take my ApoB and really suppress it down, the LDL cholesterol and ApoB. And so started something called Repatha, which is essentially it's an injection I was taking once a month. Now I take it biweekly because I think the once a month one stopped. It was really convenient. And that really lowered my cholesterol to the point where my ApoB was well under 60. Just for reference, my LDL was, right around maybe mid-30s or something like that. The idea was that in talking to this cardiologist, that if you sufficiently lower your ApoB and LDL cholesterol so much that you can actually end up reversing the potential cardiovascular disease that's already there. So I like the idea of that. If there's potential for reversing some narrowing and that kind of thing, then I was all for it. So anyway, I did start that, and that was about 3 years ago. And so this was a follow-up study. that I did, and I talked to the guy here in Los Angeles by the name of Dr. Carlsberg. Very knowledgeable guy. I actually liked the practice quite a bit more than I liked the one in Colorado. So we did the test. I don't have the results yet, but I wanted to share a few things that I learned that I thought were really interesting. And one of them, well, just so you know, he did look generally at my coronary artery CT angiogram and said I was very, very low risk of having any kind of event, although we couldn't quantify that quite yet because it needs to go through all of the other algorithms and then need to be compared to my previous tests, which it takes a little bit of time. One thing that was interesting is that my calcium score, is a little bit higher. It's now in the low 20s, which is not alarming, but again, normal is 0. I mean, when you have high risk, it's going to often be over 400, whatever. But one of the things to know is that if you start something like Repatha, or you start something that's going to do significant lowering of cholesterol, your calcium score will go up. And the reason for that is, again, the idea that these are just scars. So what's happening is that if you have soft plaques, they're actually healing up, and that leaves more scar behind. So I wasn't really concerned about an increase in calcium score. I kind of expected that, and that's what happened. That's one thing that I thought was kind of interesting. Probably the thing that I learned that I was most interested in, and this is something that I have referred to before in discussions about atherosclerosis, is that one of the wild cards out there is your LP little a, lipoprotein little a. For most people, this is not a big problem. I shouldn't say most. Well, it is most. People don't have elevated lipo little a. However, it's more common than you think. I think it's something like 20 to 30% of the population has elevated lipo little a. But let's talk about that. Okay, just as a reminder, I always talk about not necessarily focusing on LDL cholesterol as much as looking at apolipoprotein B levels or ApoB levels. And the reason for that is that it's ApoB, and ApoB carries LDL, but it also carries smaller, intermediary density lipoproteins and some of the other ones too as well. And it's really that apolipoprotein B that is kind of the problem, because that is, when it's attached to LDL, that's what allows it to go through the arterial wall and what we know as the endothelium and kind of stick there and then create this entire reaction. One of the additional variants that can happen other than lipoprotein B, another thing that we need to think about is lipoprotein little a, okay? Now, lipoprotein little a actually attaches to lipoprotein B as well. But when elevated lipoprotein little a levels are, what they're significant for is they are an independent risk factor for cardiovascular disease. And the reason it's important is the structure of lipoprotein little a is particularly sticky. And so it allows adherence to artery walls even more so than simple ApoB, and is kind of more of a thrombogenic. In other words, it creates these plaques and significantly increases the risk of atherosclerosis and thrombosis. So again, very much a genetic thing. And one of the problems with it is it's unaffected really by lifestyle, like diet and exercise. And you can't really touch it with traditional therapies like statins. They don't really affect lipoprotein little a levels. So this has been a major kind of hole in treatment. By the way, this is a test, lipoprotein little a, that everyone I think should get at least once, because you could technically have normal ApoB or normal LDL cholesterol, but if you have elevated lipoprotein little a levels, you could still be at a significantly higher risk of cardiovascular disease. So I would, again, highly recommend you try to, find out what your levels are. Speak to your doctor about getting some testing. Again, so it's lipoprotein little a, not big A. Big A is the one that is typically something that is associated with HDL. And we're not worried about that. We're worried about lipoprotein little a. Anyway, this has been a huge hole in our arsenal. So people with genetically increased levels of LP little a, basically what you would do before is you just try your best at lowering everything else and hope that the additional risk from this, from the lipoprotein little a would effectively, kind of be mitigated. But there really, again, wasn't much to do. But what I learned about in my visit with Dr. Carlsberg, who's, really cutting edge kind of guy for sure, is there are several medications that look like they're sort of on the brink, phase 3 trials that are going to be able to, I guess the best word to describe it is to silence this lipoprotein little a gene. The way these things work, there's a couple of them, is effectively working at blocking the RNA of lipoprotein little a. As a reminder, basically the way that things work when proteins are made is that you go from gene, which is DNA. DNA gets what we say is transcribed into RNA. So basically, genes are read, they're turned into the RNA version, and then the RNA version ultimately gets turned into the actual molecule itself, the protein itself. So in this situation, there is some treatments targeting RNA, and specifically one of them is called pelacarsen, and that is basically using something called antisense RNA. So maybe getting a little bit more detail, but typically if you remember anything about biology, you've got these, typically in these nucleotides, these things, they basically match up with other complementary nucleotides. So when RNA, for example, is produced, it's produced from a DNA molecule, and these RNA molecules are basically sort of reflections of DNA coding. So in antisense targeting, basically what happens is, say, for example, you have an RNA strand that is adenine, uracil, guanine, something like that, okay? And this isn't really that important. I'm just trying to give some people detail who might want to understand. The complementary base pair with that sequence, in other words, what those nucleotides want to bind with is typically one other kind of nucleotide. And what this drug does is it presents something that will essentially bind to the targeted mRNA and then essentially not replicate at all. So that's why it's called antisense RNA. There's something that's a step more complicated but similar called siRNA, which I won't talk about as well. But again, the idea is to be able to eradicate the mRNA and lower the actual production of lipoprotein little a in the blood. So this is actually pretty darn exciting, in my opinion. The other drug, by the way, is called olpasiran, Olpasiran. The first one I mentioned was pelacarsen, Pelacarsen. So if you do have the lipoprotein little a, if you have that genotype and are elevated levels, I would really keep an eye on that. That could be a huge, huge opportunity to mitigate your risk for somebody who, unfortunately, up to now, there hasn't been much you could do, even despite all the other lipid-lowering agents that we have. Okay, so that's one thing I learned. The other thing I'll mention that I thought was great was, if you remember, again, in my coronary artery disease, just a reminder of how it works. I emphasize that there really are two parts to this, at least two parts. I shouldn't pretend that I know for sure that there's only two parts, but at least two parts that are really important to the production of coronary artery disease. And one is what we talked about, lipids, right? That's probably 60 or 70% of the issue. It does seem to be the case that if you can eliminate the issue of elevated lipids and suppress your lipoprotein B, below 60, and you don't have elevated lipoprotein little a, that it's very, very unlikely that you'll have developed significant coronary artery disease. It's sort of the necessary but sufficient statement that I've used in the past. However, the other piece of I think that is, generally still under recognized in traditional medicine is the role of inflammation. And that is really, really important because, again, we talk about the second, once that damage happens with the lipids, there's a big inflammatory response that ultimately results in these plaques. Curiously, looking at this before this visit, I had noticed that there was some really interesting data out there about a gout drug called colchicine. Okay, colchicine is a drug that's usually used for gout. It's an anti-inflammatory. But as it turns out, I saw a study before that showed that low dose colchicine, which is like, in this case, 0.5 milligrams daily, there was a study that showed that in patients with coronary artery disease already, that there was a reduction in adverse cardiovascular events by 35% in those who use low-dose colchicine. There are a few other studies that actually showed that reduction in coronary artery disease and specifically outcomes of people who have coronary artery disease. Basically, people, died less and had a lot less fewer issues if they were on colchicine. So I took it upon myself to actually have my doctor put me on low-dose colchicine. Now, colchicine usually comes in 0.6 milligrams, by the way. So that's generic and it's really cheap. The dosing on the low dose is 0.5 milligrams and actually is a lot more expensive. So if you get your doctor to do this, you may want to just get the 0.6 and shave off a little bit of the medication. Right now, that I don't actually do that. I just take the 0.6 myself. But there are some side effects to this, mostly diarrhea. I think that's the biggest thing. But if you can tolerate it, then great. So I was taking this, and as it turned out, I just kind of did it based on my own reading. But as it turns out, Dr. Carlsberg actually recommends it. Low-dose colchicine. And again, this is a guy who is really, really cutting edge. So if you are potentially at a little bit higher risk of coronary artery disease yourself, you might want to talk to your doctor about that. And again, the idea being, okay, you're going to suppress lipids. You're going to keep your ApoB really low. You're going to make sure you don't have ApoA. And then, that's 60-70% of the problem, but a good chunk of the remaining problem is inflammation. How do you check for inflammation? Well, one of the things that you can check on your blood test is for high sensitivity CRP. So again, that's high sensitivity CRP, otherwise known as HSCRP. If that's elevated, that suggests some systemic inflammation, some inflammation that you might see with cardiac inflammation. So what I'm trying to do is, at the same time I suppress my lipids, I am also trying to suppress the inflammation that might be around my heart. And so that's the idea. Curiously, the other thing to note was that there's also some literature in colchicine in patients with atrial fibrillation who got, basically, they get ablated. People who have who have these arrhythmias, they have these heart rates that are basically trying to explain atrial fibrillation that are out of order, let's just say that. Sometimes you can ablate or basically electrically remove the reason for the arrhythmia. And then people who took colchicine had a much less likely of getting atrial fibrillation back again. Anyway, that might be a little bit too much information, but if you have atrial fibrillation and have been ablated, that's another meaningful piece of advice, or not advice, but information for you. Anyway, that's it for this week. Just a little review of my visit with Dr. Carlsberg in Beverly Hills. Highly recommend him if you go there and, you go in for a Clearly study and all that. Let him know I mentioned him. That's it for me this week on Sapio. This is Buck Joffrey signing off.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.